But still you're using your own body's fat in a better place. Wow.
Now, normally, what is drains? Now, normally, even in a lipoabdominoplasty, 360 degree.
Oh, 360
So, what is 360? The muscles repair a hernia if there is one.
Right. So, how was it invented?
So basically,
I've never heard from any surgeons this
pain,
one. This is amazing. Wow.
Pain is half real pain. Tubes are put in to let any fluids and serum and blood come out. The tummy tuck, even in lipoabdominoplasty, let's say we are working on the tummy.
Right.
But then, yes, because at the end of, even during the surgery, when I'm repairing the muscle, I'm putting in the local anesthetic into the muscle sheath.
Hello and welcome to this special collaborative episode brought to you by MedTalks by Dr. Anita and Expert Medical Insights by Dr. Mohan Rangaswamy. I am Dr. Anita and today we are joining forces to bring you an engaging discussion about one of the most sought after procedures in plastic surgery, the tummy tuck. A tummy tuck or abdominoplasty is a transformative procedure that not only reshapes the abdomen but also boosts confidence for those seeking to regain their shape. In this podcast, we'll dive into the questions like who is an ideal candidate for a tummy tuck? How does this procedure differ from patients to patients? What difference it makes in the patients after weight loss surgeries? What are the realistic expectations and outcomes? And finally, what sets Dr. Mohan's approach apart in ensuring safe and precise results? And how can this procedure fit into a holistic journey of self-improvement? Dr. Mohan Rangaswamy, a master in his field with over 35 years of experience in aesthetic, reconstructive, and regenerative medicine, will share his expert insights. Whether you are curious about the procedure or seriously considering it, this is your chance to learn from one of the best in the industry. So stay with us as we explore the world of tummy tucks, patient transformations, and the art of achieving natural, lasting results. Let's get started. Welcome once again, Dr. Mohan. It's such an honor.
It's all my pleasure.
Yeah, so...
Thank you once again.
Yes.
And it's always a pleasure to be with you and discuss with the audience about different exciting possibilities in plastic surgery. And today we will be talking about
tummy tuck.
Tummy tuck,
Yes.
in-depth, extensive, complete.
Exactly. Thank you so much once again, because we are actually on a mission, as we always say, that people should know what are the advancements happening in plastic surgery and everything. So in tummy tuck, we'll start with what exactly is tummy tuck? How was it invented?
So tummy tuck is a procedure where we are aiming to remove the excess flabby skin. And today we are also aiming to remove excess fat,
Right.
tighten up the musculature, repair any gaps in the muscles, repair a hernia if there is one, and restore the abdomen to not just a flat abdomen, aesthetically beautiful abdomen with hills and valleys and all the various
Or the six packs.
shadows, not necessarily just the six packs. You know, there are various aesthetic points like the valleys on the sides, the groove in the middle, the nice narrow waist,
Right.
waist-hip ratio. So really what everybody instinctively knows when they look at a young, well-toned abdomen without going into dissecting the various parameters,
Right.
instinctively you say, wow, this is a beautiful abdomen.
Yeah.
So that has certain parameters. So we are trying to up the ante and improve our results day after day, month after month, year after year
True.
to really reach that goal of the beautiful natural.
But then what's difference between tummy tuck? This is tummy tuck. So
This is
difference
tummy
between abdominoplasty, which is also a terminology?
Abdominoplasty is a medical term for what is commonly known as tummy tuck
Okay.
in the lay language. Yeah,
Right.
They're both the same.
Right. So how was it invented? Coming to the
So
same question.
basically, the abdominoplasty, as we know today, is a more modern innovation. But almost 200 years back, people were doing surgery to remove excess huge abdomens which were causing a load on the patient, or they were even using it to cover some wounds in war wounds, use this skin to cover.
Okay.
But basically around 1910 or something is the recorded history of the first abdominoplasty, at least to some extent resembling our modern procedure.
1910.
But 10 by, I think, Dr. Kelly. But remember, in those days, they were removing the umbilicus also.
Oh.
The concept that umbilicus can be retained and you can jump over it and pull the upper abdominal skin also down, today it seems like, passé, but it's a leap of faith.
Umbilicus is the navel.
The navel. But it's a leap of faith. And this was Thorek, if I remember right, who started this or published this method. So you cut around the umbilicus or the navel, and then you can incorporate and pull the upper abdominal skin also down. So that was a big jump, which today seems naturally, but it took a leap of faith to be able to do that, to say that this umbilicus will survive on the blood supply from below. Anyway, without dilating too much onto it, between 1960s to 1980s, there have been some very prominent names. Professor Pitanguy and his unit in Brazil is an important contributor to various concepts in abdominoplasty, okay? Including the incision, there is handlebar incision, there is a W incision by Regnault. So they were refining the incisions, they were refining the shaping, but still they were not, liposuction had not yet been invented. So they were just cutting out the fat from below the flaps. And therefore it was important that tummy tuck is only for people who are not obese, who should have thin abdomen but flabby, loose skin.
Right.
That's what it was for. And the muscle repair also was invented and perfected upon. Next jump comes around 1995 or something. So where how you should put the tension, Lockwood, Ted Lockwood said that you must pull the lateral part, outer part up and produce tension. He also brought the concepts of not dissecting all the way. You see, before they used to dissect all the way to the chest.
Yeah, I mean, I cannot believe umbilicus also, they removed the navel also.
No, that was way back. But after, let's say, 1950s or 60s, the umbilicus was being relocated, etc. But they were dissecting the skin all the way to the chest wall. Therefore, they were cutting all the blood vessels, all the nerves. So the skin used to be numb. It was Ted Lockwood who brought selective dissection. Around that time, see, this is around 1995 this paper came out. Around that time, the inventor of liposuction, okay, Dr. Illouz, was independently publishing in France that you can do liposuction and after that you can just remove the lower skin without any dissection. You can pull it down. And he said liposuction does half the job. So this was a time when I had moved to Oman, and for the first time in my life I encountered the kind of obesity which I don't see in India. And there were patients coming for tummy tuck. And by classical teaching, I'm not supposed to do a tummy tuck until she loses weight.
Right.
But that means I'll be rejecting 95% of the patients that are coming to me.
True.
Simultaneously with this, I was doing liposuction in many women and then realizing that actually the skin is now loose. And in one of them in particular, I tried to remove a little bit of skin from the lower part.
Is this the same patient whose picture I have seen?
You have seen.
I would like to show it in our show. In between, I'll show our audience.
1995.
That's a huge transformation.
So there, once the skin was removed, then I realized that the effect of liposuction, like a honeycomb, has really mobilized the skin. So without snipping all the blood vessels and nerves, I can actually move the skin down. Now, I come from a reconstructive background. So there are important blood vessels around the navel, which we use actually in reconstructive surgery.
Okay.
So I'm actually very reluctant to cut those vessels. So I said, let me work around those vessels. Let me preserve them until the very last. If I am forced to cut them in order to move the skin more, I shall do it. But then I realized that without cutting them, I'm able to move the skin all the way down.
Man of innovations, yes.
So something was clicking in my head and then I started doing this. But I wasn't so sure that I was on to something really the next leap or the next important jump.
Right.
Until a paper was published in 2021 and I kicked myself. I said, I should have published this.
Oh.
But the first paper on this concept of combining liposuction and tummy tuck in what is called lipoabdominoplasty was published in 2021.
So silently you invented
I was
silently
doing it.
You have invented it.
Invented it. Okay. So we can say I'm a co-inventor or, the idea, let us say, the idea, its time has come. So different people in different parts of the world, unknown to each other, were working on the similar idea. You must understand that at this time, it was a dictum that you should not combine liposuction and tummy tuck. That dictum has still some truth because if you did liposuction fully and did the tummy tuck in the old-fashioned way of lifting all the skin up, then you have destroyed pretty much all the blood supply and you have a high risk of complications.
Right.
That's why Matarazzo and such respected figures initially cautioned against combining liposuction and abdominoplasty. Later, they themselves revised their opinion that as long as you follow these precautions, you can combine.
Right.
So that's how I started combining. And then soon enough, it was recognized that this is very good. And I have been invited in many conferences to actually show live demonstration surgery as well as to teach junior surgeons. And then soon enough, I wrote a paper of 120 cases consecutive that I have done, highlighting
120 cases.
At that time. Now it must be almost 1,000. So highlighting the safety aspects, highlighting the feasibility and how to do it and so on. A few years down the line, I again published on how to prevent complications in abdominoplasty. So you see, until these innovations came, abdominoplasty was associated with a higher complication rate. But then today, it's much, much safer.
Right. So just to let our audience understand in their language, who are the people who can go for this kind of procedures, the ideal candidates?
Okay. So the ideal candidate is somebody who's not obese viscerally.
Fat viscerally.
What do I mean by viscerally? See, if you have fat under the skin, which you can grab with 2 hands, that's okay, because I'm doing liposuction, I can remove it.
Okay.
But they should not have excess fat inside, behind the muscles. Okay, and there are simple ways to make that out.
So that's visceral fat.
That is
and
visceral
liposuction
fat.
is removing the superficial fat.
Liposuction is removing the superficial fat. It cannot remove the visceral fat.
Right.
So what happens if the visceral fat is too much and their muscles are also separated? If I try to close the muscles, there is pressure.
Right.
Visceral fat is like having a baby inside. Okay.
Right.
Let's say you see a man and he's got a pot belly. He's got a baby inside. That baby is called fat.
Right.
A pregnant woman has a big tummy. She has a real baby inside.
Right.
So if somebody is obese on the inside, then that person is not a good candidate for tummy tuck. So should not be obese inside. But you can have fat externally because I can remove it.
Okay.
So that's one. Loose skin, which is hanging down. If there are muscle separations, we can repair it at the same time. And preferably the lady should have, I'm talking about ladies, should have finished her childbearing responsibilities. Like she's not planning any more children.
Okay.
Tummy tuck is also done sometimes in men. And those are men who have lost a lot of weight after initially having been overweight. Now they have loose skin, like a woman who has given birth to children.
Okay.
Because he had a different baby inside him.
Right, different kind of a baby. So what about the scars?
So these are the people who are best candidates for a tummy tuck.
Okay.
Yes.
What about the scars? Like too much of scars are there or?
Not really. In tummy tuck, the way it is performed, the scar is very low. It actually goes inside the bikini or inside the undergarment.
Okay.
So it's not visible, even in a 2-piece suit. Yeah.
So Dr. Mohan, what are the advancements that has happened in this and how does the latest tummy tuck procedure differs from the traditional ones?
Okay. So we talked about the classical operation and then came this high lateral tension, which I talked about. And then came the lipoabdominoplasty, which we just now talked about.
Right.
Once lipoabdominoplasty is now become almost mainstream, several improvements have happened. We are pushing the liposuction more and more. Now that we know that blood supply of the skin flap is maintained because we are preserving some blood vessels, why not do more liposuction? So the envelope has been pushed to the extent of causing what is called a high definition abdominoplasty. Then there are people who want to make the muscles tighter. For example, we close the midline muscle, but sometimes people have bulging on the sides because the side muscles are weak.
Okay.
So there are procedures to tighten the side muscles by plication.
Oh.
Okay. So that gives you even better contour in the waist and on the sides. Wow. We have already sorted out the midline.
Right.
Now the sides.
Right.
Okay. So this is another advance. A very significant advance in which I have also been a contributor is to do tummy tuck without drains.
Wow.
Now normally, what is drains? Now normally, even in a lipoabdominoplasty, at the end of surgery, 2 tubes are put in to let any fluids and serum and blood come out.
The one which is collected during the procedure.
under the skin, which collects after the procedure, like because of oozing. Because we have done a procedure in a wide area, right?
Right.
There will be oozing of fluid.
Right. So normally these 2 tubes are hanging out.
So even today, these drains are used, and they give rise to some pain, and it's kind of considered as a necessary evil. And the drain may have to be kept for 2, 3, 4, 5 days, sometimes even 7 days, until the drainage amount becomes less, and then people remove it, because surgeons put it in for fear of, if they don't put it in, maybe the fluid will collect and cause what is called a seroma.
Right.
Now again, I took a break from the routine. I said, why do I have to put these tubes? Why don't I close the space inside? And again, I'm not the sole inventor of this. This concept was promoted by Riccardo Barudi and a few other people, Pollock. So there were various concepts, all coming to the common idea that the space between the skin and the muscle, which we have created now, should be closed.
So there's no
by
fluid
internal
collection.
stitches. So there is no
itself.
space for the fluid to collect.
Right.
So therefore, drain becomes unnecessary.
Right.
It's not just this. There are a few other things that I incorporate. For example, I use very low power on the cutting instrument called diathermy. You see, we use a machine called a device, pencil-like device called diathermy.
Right.
This diathermy has electricity coming through, and it's able to cut the tissues.
Yeah,
and
that pen thing which you use for
and simultaneously seal the blood vessels.
Right.
And almost all surgeons use this device. Now, what I do is I use a very low power.
I've seen doctors being harsh with that.
Yes, it can be a harsh instrument.
Yes.
But what suffice it to say that I am paying attention to every aspect of the procedure to minimize the trauma to the tissues, and tissue rewards me by healing faster, by producing less fluid outpouring. Therefore, I have a zero seroma rate. I don't use a drain. Last 25 years, I have not used a drain.
25 years?
Consecutively. And I don't have any seroma in my patient. So my seroma rate is 0.
Wow.
So I think this is all this was crystallized, all these ideas that were floating in my head, which I have put into practice, I crystallized them into a paper, which was published, to say what are the root cause analysis of complications and how to minimize complications in a tummy tuck.
Right.
Going by root cause analysis. So every complication that has happened or that is reported in a tummy tuck, I took up that complication, analyzed it. Why does this happen? What is its root cause? Can we go to the root cause of why this happens?
Right.
And therefore, how can we prevent this?
Right. So if our audience has any questions about the procedure, they can approach you
Absolutely.
And place a comment, where they can be answered.
Yeah. Ask your questions in the comments and we'll try to answer.
Perfect.
So you were asking me about modern advancements. So drainless abdominoplasty, higher definition, okay, and better tightening of the muscles. The other thing is 360 degree.
Oh, 360
So what is 360 degree? In a tummy tuck, even in lipoabdominoplasty, let's say we are working on the tummy.
Right.
But then there will be excess fat on the sides.
The love handles.
Hip bulges will be there.
Is the love handles, right?
Yeah. Hip bulges will be there. So on the ends of the abdominoplasty scar, the tummy tuck scar, there is still a bulge.
Right.
And the patient is worried about, now what about this bulge? Because she now notices this bulge. Everything else has become flat. So in people who have fat on the sides and more fat on the back, a tummy tuck is only a half job.
Okay.
Because the abdomen is a cylindrical structure, right?
Right. It will adjust itself, no?
It's a three-dimensional. No, it doesn't adjust itself. It's unforgiving. If you left fat on the sides,
it's there.
It's there.
It's going to be there.
It's there.
Okay.
Now, you can't take that fat out from the front approach because already you will be hitting against the table which is under the patient. You got to turn the patient, right?
Right.
A little bit we can turn and approach. But really to do a proper job, 360 degree, I start with the prone position. That means the patient is sleeping
on the tummy.
face down
Sleeping
on the tummy. We do the back liposuction. And if at this time, if the woman needs her buttocks to be augmented, if she has hip dips, if she desires to have, well-rounded, well-shaped, maybe bigger buttocks, then I can transfer this fat by injection in what is called fat transfer. It's done at the same time when we do the liposuction of the back. Let's say this takes an hour, hour and a half. Then we turn the patient. And then I perform the tummy tuck. Now I'll tell you something very interesting. Many people don't believe this. This liposuction in the prone position is done under local anesthesia with sedation. Not GA. So it's very easy for the anesthetist also. The patient just sleeps on her tummy. She's just sleeping. And I give the local anesthetic and I perform the entire liposuction, fat grafting to the butt. Everything is done and finished.
Wow.
Then we ask her to turn.
Herself.
She will turn.
Wow.
Because by the time the anesthetist has reduced the drugs, so she's slightly coming to wakefulness, we say, okay, you turn, she turns. Once she turns, again, we give more medicine. The anesthetist gives more medicine, goes into deeper sleep. And then I begin the liposuction of the abdomen, still under sedation. No GA.
Wow.
We finish the liposuction on the tummy because in lipoabdominoplasty, I have to do the lipo of the tummy first, complete tummy, complete abdomen, finish that, then only make the cut to raise the skin. Now, when I'm about to make the cut to raise the skin, I discuss with the anesthetist, shall we proceed in the same way or will you now like to give general anesthesia?
Okay.
Let's say 80% of the time, he will give general anesthesia, he or she will give general anesthesia at this time. Then I perform the remaining part of the tummy tuck. So the GA, general anesthesia time is just about 1.5 hours to 2 hours. Sometimes, if the patient is so good and we don't have to do major muscle work, let's say, and the anesthetist says, doctor, it looks like fine, you can continue in this way.
Wow.
So I continue the tummy tuck also under sedation plus local. So we can finish the whole thing.
Wow.
Now, here comes another innovation. I forgot to mention earlier. One of the other innovations I started way back
So we
in
finished 360?
360.
That was
we
360.
finished.
So by the time patient is awake, completely transformed from all the
Completely
angles. Huh?
transformed, yes.
Wow.
Nice narrow waist, flaring hips if she wants that, bigger butts if she wants that.
So that fat has been used to put in a better place
yes.
at the same time. It's amazing.
Put to use.
Wow.
And what's more, if breast needs to be enhanced, if it has lost volume, let's say
Right.
post-pregnancy, I can transfer the remaining fat to the breast also. So it is a total mommy makeover transformation.
Natural looking breast, right?
Natural,
Right? Because
natural.
nowadays people
No
use
implant.
implants and
No
all,
implant.
and that proper
No, both are good.
artificial shape is there.
No.
But fat grafting gives a natural look.
Fat
doesn't it?
grafting has certain limitations. For the breast, you can only enhance it to some extent.
Right.
Upper pole and cleavage. And
Right.
let's say half a cup size more you can give. But if somebody wants a more significant or needs a more significant restoration of volume, we have to use.
But still, you're using your own body's fat in a
you
better
have to
place.
you have to use an implant or implant plus fat combination. But we are digressing. We are going into a different topic
Right,
now.
right,
Yeah.
right.
Coming back to tummy tuck, I forgot to mention earlier, I started way back in 2005 or 6, I started using long-acting local anesthetic into the muscle. You see, patients after tummy tuck, the pain that they have, whatever pain they have, is not in the big incision down below. You would imagine that to be painful. It's not. It's the midline where I have done the muscle repair.
Okay.
She feels the pain, especially when she moves.
Ah,
So that restricts their breathing also a little bit.
okay.
So again, my philosophy of going to the root cause, analyze the problem, fix the problem. So I said the pain is coming from the muscles. Why not give local anesthetic in the muscle?
Right.
So I started injecting long-acting local anesthetic way before these things were described in the world literature.
Wow.
And then I found that the patient doesn't have pain in the first day.
In the first day itself.
Yes, because at the end of, even during the surgery, when I'm repairing the muscle, I'm putting in the local anesthetic into the muscle sheath by injection. Earlier I was placing in fine catheters, but now I don't think it's required. I just inject the local anesthetic and that takes care of it for the next 8 to 10 to 12 hours.
Wow.
Okay. There is a medicine called Exparel. It's not available in Dubai. If it was available, I would use that. And that would give them pain relief for up to 36 hours. But we don't have that. So this is called a rectus sheath block. So rectus
The
sheath,
front muscle.
yeah. So the rectus sheath block is another of my contributions. So therefore, the way I do my tummy tuck is lipoabdominoplasty with no drains, with the local anesthetic given for the rectus sheath block. So patient wakes up with no pain.
Wow.
Patient may start having some pain in the morning next day. By the time they are taking their tablets, and you see what happens if the person does not feel pain in the afternoon and evening of surgery, much of the anxiety is gone.
True,
You see,
true.
they are deep in their hearts, they are afraid that I'm going to wake up and I'm going to have so much
Yeah.
pain. And it's a pleasant surprise. I don't have pain.
True.
That does something to the brain.
Right.
That even when the pain starts actually appearing the next
They are
day.
prepared for it.
No, it's a very peculiar thing. The local anesthetic is gone.
Right.
It's only 8 hours to 10 hours it will work. So next day there is no local anesthetic in her muscle.
Right.
Yet she feels much less pain than a patient who never had this local anesthetic given. Because the pain pathway did not get established.
Oh.
So this is called preemptive analgesia. That means you preempt the pain by giving pain blockers such that the pain pathway is not established. So when the pain actually comes, it's less.
I've never heard from any surgeons this one.
pain-
This is amazing. Wow.
Pain is half real pain and half the effect of mind over pain. Like the same standardized pain, you give it to 10 people, each one will react differently.
True.
Some of them are stoic. They say, oh, that was fine. And some of them will bring down the roof.
Right.
And we see that in day-to-day practice.
Yeah.
If you give an injection,
Especially this procedure for females. I mean,
if you give an
sorry.
injection to somebody, in some people, the reception will hear it.
Oh, true.
True?
Seriously.
So, no, coming back to
our baseline, yeah.
to what is the real life experience with different human beings. Different human beings have different pain tolerance, different pain perception, because pain is personal. Anyway, again, we are digressing.
Right.
So getting back to the tummy tuck. So these are some of the innovations which ensure that the patient recovers very easily. Next day they go home. There are no drains.
Next day itself going home.
Yeah, usually most of my patients stay
Even
only
for
1 night.
360 degree?
1 night.
Wow.
1 night. If they are from outstation, they prefer to stay 2 nights. Yeah. And then they can go to the hotel, and from there, they can just take their pain medications orally. Again, antibiotics, we give only 1 or 2 doses. So they are not prescribed antibiotics when they are discharged.
Wow.
So they only take simple pain medications, and that's quite sufficient.
Wow. Yeah. How is pregnancy and lipoabdominoplasty related? Is there any correlation?
Well, the lipoabdominoplasty is usually performed for women who have had children. So that's what stretches the abdominal muscles and the skin.
Okay. So the most ideal candidate?
The ideal candidate as well as the candidate who most needs it.
Right. Okay.
Right. For example, let's say a woman has never given birth to children, but she was a bit overweight, or she is overweight and she has a tummy.
Right.
That woman would be a good candidate for liposuction.
Okay.
So how do we choose?
Right.
Generally, if a person has had children, let's go with the understanding that 80%, 90%, she is going to require a tummy tuck and not just liposuction. Right? There is rarely some cases where a woman has had 2 or 3 or even I have seen 5 children. She has given birth to 5 children and abdominal skin is pristine.
Wow.
And I do only liposuction. So how do you decide this? If the skin has stretch marks, the elastic fibers are broken.
Okay.
That woman is going to require that skin to be removed because the skin will not shrink back after liposuction.
Okay.
Number 1. Number 2, if there is muscle separation, sure, you're going to repair the muscles, right? And you need a tummy tuck. You need to lift the skin to repair the muscles.
Okay.
That's number 2.
Okay.
Number 3, if there is a hernia associated with it, again they are going to
hernia is that
where there is a gap in the muscles and some intestine
something comes out, the protrusion.
When they cough, it protrudes.
Right.
Okay. So
for hernia, so 3.
So these are the cases where definitely you cannot do liposuction. You need to do a tummy tuck. Or if there is hanging skin or if there is loose skin jiggling up and down, sure, this is not a case for liposuction.
Right.
So those cases are patients candidates for tummy tucks.
Okay. So Dr. Mohan, how are the expectations of patients changed in the past decades with a tummy tuck?
Okay. See, it's something that we experience not just in tummy tuck, in every field of cosmetic surgery. As techniques improve, as surgeons are giving better and better results, right? The patient's demand increases.
True.
They are on to the next planet.
Next level.
So the patient demand is not just with respect to tummy tuck. In the entire spectrum of cosmetic surgery, as our techniques evolve, and as the results that plastic surgeons are giving improves and we are able to give better and better results, the patients jumping to the next planet. Their demands increases. So in a way...
Same like a husband-wife probably. When the husband keeps fulfilling, the wife's demand increases.
Well,
yeah.
Okay.
Jokes apart.
So it's actually the demand from patients, which is the driving force for innovation. That
True.
Can we meet
Absolutely
that demand?
agree.
So in a way, that is a positive thing because we have a goal to meet. We have to enhance our act.
Absolutely.
We have to get our act, up our act.
Right.
But there are limits. There are limits set by human tissues, by the biology of tissues, by the tissue response, and by safety. What do I mean by this? You can go on doing a hell of a lot of liposuction. You can justify it and say, I'm going to give high definition. Patient is demanding. She's a very demanding patient. I'm trying to give her the best result. Somewhere along the way, you will cross that safety threshold and you will produce complications. And there will be skin necrosis and this and that. Then you wonder, was it all worth it?
Yeah.
Now, here is a demanding patient who wanted the perfect result. She wants 6-pack. So coming back to the demands, nowadays people want 6-pack. People want... an 18-year-old's figure. So that is actually unrealistic.
Right.
Although our performance is improving, we are able to give better and better results. Sometimes I sit back and look at the photograph and I say, wow, how did we achieve that?
Right.
But that is one aspect.
True.
The other aspect is safety. And I always keep safety first. And every time, once in a couple of years, I come across a horrible complication. Somebody went somewhere, got a surgery done, and they got a horrible complication. They come to me for fixing that complication. I look at that complication. I say, wow, this person went for a cosmetic procedure. Otherwise, this person is a healthy person.
True.
Now she's landed up with a huge medical problem.
With a cosmetic procedure, imagine.
And so this cannot be justified.
True.
So I always, keep safety uppermost in my mind. So I would not do crazy high definition liposuction if I think that it might increase the chances for complication. Everything is a matter of statistics, right?
True.
And we can't push human tissue beyond its tolerance.
Absolutely.
We have to ultimately see, this is the only field where we are pushing the tissue in order to get results, right? So in no other surgery, for example, in any other surgery, they make an incision, go fix the problem, what needs to be fixed. If the kidney is at fault, if the gallbladder is at fault, fix that and come back.
Right.
They're not pushing the tissues to change the liver shape into some lily flower
Exactly.
and things like that.
True.
It's only in cosmetic surgery where it is demand driven by the patient. So we have to sometimes hold them back.
Stop. Yes.
Look here, this is not realistic.
Right.
What you're asking for compromises safety.
Right. And there are very less doctors who really make patients understand that this is where you have to stop.
I would rather lose a patient than just blindly listen to everything the patient demands, because she comes from her zone of knowledge or relative ignorance. I'm supposed to be the expert, and I am coming from my knowledge background.
Exactly.
And I have to moderate her request, and I have to counsel her.
Absolutely.
It's my duty.
Absolutely.
It's my duty. If she doesn't like my advice, thank you very much. I hope she doesn't go to somebody who's more than willing to accommodate her request and end up doing something which will be a disaster.
I mean, this is the reason of the redo cases which you come across, right?
Redo is
The
an
complications.
unsatisfactory result or some complication. Right. That is one aspect of redo. The others are disasters. Disasters which are now cause a medical problem.
Oh.
Let me give you an example. Like say somebody does a tummy tuck. The lower abdominal skin dies. Now you have a huge gaping hole. You have a huge wound,
Whoa.
painful, infected with pus.
Oh my goodness.
It's a misery. How can we justify that? But it can happen.
True.
It can happen.
True.
Why would that happen? Somebody did excessive liposuction. Somebody lifted all the skin. Now you see, when you do liposuction, you have to preserve blood vessels.
Right.
If you did the old abdominoplasty, and then you didn't see the nuance, and you say, okay, everybody is doing liposuction, let me also do liposuction. Then you do high definition because patient is asking you to do it.
Right.
And you forgot that the patient is a smoker. You never even took the history. Are you a smoker or not a smoker?
Ah.
You see, smokers have a high chance for skin necrosis.
True.
And then you put a tight bandage because you want shape. And you put a corset.
Oh.
You've done
You're
everything
killing
wrong.
the person, like
You've
literally.
done everything wrong.
Oh.
You've taken a smoker. You've done extensive liposuction. You've cut off the blood vessels for lifting up the skin. On top of it, you put an extra tight corset. And is it a wonder that the skin died?
Oh.
So, cosmetic surgery is not just taking and chiseling the body. First, and this is something every plastic surgeon must remember, and the patients must also remember. First, I'm a doctor. Then I'm a surgeon. Then I'm a plastic surgeon. And then I'm a cosmetic plastic surgeon. And then I'm specializing in a particular type of, let's say today we are talking about lipoabdominoplasty.
Right.
So all that medical knowledge must contribute.
True.
You must see that the patient doesn't have any other medical conditions or something which can compromise your safety.
Agree.
So safety paramount.
First.
Paramount. Okay. Within limits of safety, if you can achieve excellent results, that's the beauty of well-balanced cosmetic surgery. Always keeping the patient well-being in mind.
And that's Dr. Mohan Rangaswamy for me.
Well, many people.
No.
Many people.
This
who are
this
good
precision is
surgeons.
what makes you different.
So
I
we
mean,
have to be.
it's
We have to
totally
be. We have to be.
amazing.
There's no compromising on safety.
Amazing. So after hearing about this, all possible complications, Dr. Mohan, I'm impelled to ask you, who are the candidates who are not eligible for such kind of procedures? I mean, so that they can be careful.
Yeah. Before I answer that question, I just want to re-emphasize here that if all these precautions are followed, and if the patient selection is done properly, today's modern tummy tuck lipoabdominoplasty, the way I do it, is very safe. It is a major surgery. It can have its own set of complications, but by doing this root cause analysis, I'm very happy to share with the audience here that I really have to search back to see, have I had a complication? Touch wood.
Wow.
So I've not had a seroma. Last 10 years, I have not had a bleed. Last 10 years, I have not had any infection. I have had in my entire career only 2 major infections in the abdomen, in abdominoplasty.
Uh-huh.
No deep vein thrombosis. No major lung issues. No major issues whatsoever.
Wow.
A few cases where there has been a little bit delay of healing here and there, requires a minor something or the other, and it's all sorted out in the clinic.
Beautiful.
So I always say that if somebody can do abdominoplasty even with 360-degree lipo, even with fat transfer consistently with this degree of safety, therefore these techniques are good.
Right.
Therefore, somebody should not have a high rate of complications. If you have a higher rate of complications, you must introspect. Why?
What went wrong?
Why? Because this is the standard of care
Right.
today. Okay. So now having talked
Ineligible
about that,
candidates.
yeah, candidates who are not eligible, first of all, who have a significant obesity,
Okay.
who are medically unfit,
Okay.
who cannot lie down flat, whose heart is not working well. They are not candidates for any cosmetic surgery, by the way. And if they have a lot of visceral obesity, we talked about it, the inside is fat.
Inside fat.
Then by doing a tummy tuck, I'm not going to give them a nice shape. They're not going to appreciate it because they're still convex. And they have been put through this risky surgery, potentially risky surgery, when they are medically unfit and there was a lot of obesity inside. So it's not a treatment for weight loss.
Okay.
Then if they have conditions where they're, they are on blood thinners or blood thinners cannot be stopped,
Okay.
they still have unsorted heart problems, uncontrolled diabetes, uncontrolled hypertension, BP. So all these common medical issues, if they are controlled, on the contrary, and also unrealistic expectation. Somebody's got four children, he's got a big tummy, he's got all these things, and he's expecting to look like, she brings an Instagram photo of a svelte 18-year-old
Oh God.
girl with a trim abdomen. I say, sorry, no, you cannot get this.
Right.
You cannot get this. So we have to be realistic. So I show them various photographs of my own patients to say, so they can see, okay, this is what is realistically possible. If they are happy with that, they will proceed. If they think that no, Dr. Mohan's results are lousy and I'm going to look for somebody who can produce me this,
Oh my
good
God,
luck
this
to
is a
them.
disaster they will do.
Good luck to them.
Oh.
So those are also
Not eligible.
not suitable patients. Then people who are psychologically unstable, difficult to spot them, by the way, and what is called body dysmorphic disorders, and they would have a long history of having done various procedures, many of which unnecessary.
Okay.
They keep on chasing, and the goalpost keeps shifting. And they would give you a history of 5 or 6 procedures that they have done, and they would be bad mouthing the doctor who did.
It's BDD, right? Body dysmorphic disorder.
So those people we have to not accept them. So
right.
they are for their own good. Their own good.
Right.
So these are some of the cases which are not suitable for tummy tuck.
I want to understand also one more thing, Dr. Mohan. For pregnancy, you said patients who undergo this procedure cannot plan for pregnancy. How is that related?
It's not exactly
whoever
that
has
way.
done
It's not
finished
exactly
pregnancy.
that way. It is preferable that they would have finished childbearing. For example, in tummy tuck, we're removing the lower half of the abdomen, right? The skin from the belly button to the pubis is
So
actually
basically,
removed.
we're not leaving the skin to expand.
And the skin is pulled down and tight. So
Right.
this skin now has to expand. So let's say she now only has 50% of her original abdominal skin. Let's put it that way.
Okay.
Now she gets pregnant and that one stretches.
True.
Well, a couple of my patients have become pregnant, maybe unplanned pregnancies, and they have successfully delivered. Yes. And sometimes the results, after this, the results will, not be the same.
Right.
There will be further relaxation of the muscle, further laxity of the skin.
Right.
Some of them may regain back. So if it happens, it happens.
But there is no harm.
There is no harm. There is no harm.
Okay.
I do get patients who need a tummy tuck who are either not married or they still want to have more children, but they want to have a tummy tuck anyway because they can't tolerate this big hanging
Right,
tummy.
yeah.
And they say, okay, maybe we will have another baby after 3 years, 5 years, who knows. So in those people, we have a honest discussion. I say, okay, I'll do your tummy tuck, but I will not pull the skin so tight.
Okay.
Okay? We'll be a little bit conservative on skin removal. So we leave you enough skin so that in case you get pregnant, there is no issue.
Wonderful.
And then if there is a cesarean, then the doctor can go through the same incision. No need for a new incision.
Okay, great.
Yeah. See, the tummy tuck incision is from hip to hip, whereas cesarean is 1/3 the size.
Right.
So you can take a cesarean and multiply 3 times, times 3. That will be usually the length of the tummy tuck incision.
Okay.
But it's in the same plane.
And
same
the scar
line.
is visible?
Well, all scars are visible. because you cannot make an incision or a surgery in a human body and wish for the scar to disappear.
Right.
It may only happen in the rare few exceptions.
Right.
Almost disappear, but most of them it will be visible. Now, that brings me to another interesting question. People who have a cesarean, many of the women who come for this already have a cesarean scar. Will it be like this? This is what they ask. And I tell them, look, when you were pregnant and you had a cesarean, that is the best time for the best scar. Nobody can beat a cesarean scar. So although I'm a plastic surgeon and I'm doing this tummy tuck with all the care and attention in the suturing and everything, my scar will be 1 or 2 degrees inferior to your cesarean scar. That drives home the truth because they are expecting otherwise, and I better clarify this. Why? Because at that time the skin was loose, the pregnancy hormones are running in the blood, whereas here there is no pregnancy hormone. I am actually making it everything tight, and tension is the enemy of scar.
Right.
So that's why in my suturing, I take all the tension on the deeper tissues so that there is no tension on the skin.
On the superficial level.
Skin. So usually patients tell me that, doctor, your scar and the scar that you gave me, I've seen other women and my scar is pretty good and I'm happy with the scar. So again, attention that is paid to how the scar is closed is also very important in the result. However, this scar, I mean the cesarean scar will always beat a tummy tuck scar.
Right. Right.
That will always be the better scar. Just a point of information.
True.
Interesting
Absolutely.
information.
So, Dr. Mohan, what's your take on the fat losing techniques, which are most, very much in common nowadays, like fat freezing, those machines and all, non-surgical techniques?
A lot of clinics are promoting these non-surgical fat reduction methods.
Yeah, those big machines, you know.
Some are using fat freezing, some are using lasers, and some are using injections. See, they have a very limited role. When you have small localized collections, say in the arm or under the chin or something, it can be used.
Okay.
And they are not that predictable. Anyway, in tummy tuck is a much bigger game. There's a lot of loose skin, there is stretch mark, there is muscle weakness. These things can never be sorted out by these non-surgical methods. So if somebody is a candidate, really after examination, she is a candidate for a tummy tuck, she is a candidate for a tummy tuck.
Right.
Now, often I get asked a question, doctor, what exercise can I do? Can't the exercise fix this loose skin? Can I avoid surgery? Look, this surgery is elective. I'm not saying that everybody with a little bit of loose skin, a little bit of muscle separation must undergo tummy tuck.
Elective as in planned?
Planned
surgery.
By choice. It's not a medical necessity.
Agree.
It's something she will choose to do for the sake of a better body shape and her self-image and confidence, how she fits into clothes, how she looks, and so on and so forth.
Right.
However, the question that, can
Exercise,
I fix this by exercise? Exercise has zero effect on skin. This is an often repeated statement that I make during a consultation. And they look at me like,
I'm looking the same way.
I said, yes, you heard me right. You heard me right. Exercise has zero effect on skin. Exercise has a good effect on reducing the visceral fat, making the fat cells shrink. It has a good effect on your cardiovascular general health. It can improve your muscles, it can improve your posture, and it can improve your strength, general well-being, and all that, and important for health. But if you have loose skin, especially stretched by pregnancy, especially with stretch marks, then that's it. Exercise cannot fix that. Similarly, if muscles are separated, no amount of abdominal crunches can get those muscles to join again. If there is a gap of 1 to 2 centimeters, yes, okay. We don't really need to surgically fix that. But some women have a wide gap, and that can only be fixed by surgery. Now, how do we know? How can a woman know that
because on YouTube, there are so many videos, you correct your gaps, muscle gaps, this exercise, that exercise.
No, they don't work. Unless the gap is just about like 1 thumb width, 1 to 2 centimeters.
Okay.
Right. So, how can somebody know herself?
Right.
So, very simple. Lie down and raise your head and shoulder 6 inches off the bed.
Okay.
And look at the belly button. Look at that area. As you raise, what happens?
Okay.
There's a little bulge appearing there, like a little mountain. Okay, you have muscle separation. And holding the same position, put your finger like this. And you can go in with the rigid fingers. And you can feel one muscle on this side, one muscle on this side.
Really?
You can actually feel the gap.
Wow.
And since you're a doctor, I can tell you, if you now ask her to relax, put your finger there, go down a little bit, you feel aortic pulsations.
Oh, really?
Can you imagine? Aorta is the major vessel in front of the vertebral column.
Right.
Because there is no muscle. The muscles are separated. In between, there is just this paper-thin skin. stretched out skin. You can press and you can feel the aorta.
I'll try. Excites me.
So this way, anybody can easily diagnose that the muscles are separated.
Okay.
And then if the muscle separation is significant, tummy tuck is the only solution.
Right. Right. So, how does a patient's journey look like in this, Dr. Mohan? If a patient is coming, how should they be mentally prepared that this is how it is going to happen from the beginning to the end?
So, after consultation, I prefer to have 2 consultations so that there is enough time for answering all the questions. Then they sign a bunch of consent forms. They get blood tests done. They get to see the anesthesia doctor who determines their fitness for anesthesia. The date of surgery gets booked. They come to the hospital 2 hours before surgery. And then they get taken in for surgery. We have already described the surgery. After surgery, they come to their ward, stay overnight. Nurses will take care of their medications and stuff. Evening, they are encouraged to walk. If they are unable to walk by evening, at least definitely by next day morning, they should walk. In the beginning, they may hold a walker and walk slightly stooped, slightly bent. I ask them to walk with a slight bent for the first 4 days.
Okay.
And day number 5, they should become straight. And day number 5, they come back for a review and they come walking straight to my clinic.
Wow.
And usually they come walking straight with a smile on their face because they are not suffering in pain.
Wonderful. That gives a good feel.
So the pain is usually on the first day. The day after surgery is the first day. So sometimes, like I said, pain is an individual thing and different people react differently. If on that day she feels pain, and she's not ready to go home, we're not going to push her out of the hospital. We say, okay, stay one more night. By tomorrow, you will feel better. By the time she has walked around, her confidence is better.
Gain back.
The next day, she feels confident enough to go home.
Right.
At home, she has to keep the bed slightly bent. Now, you don't have hospital type of beds. After care. At home, you don't have a hospital bed which head can be raised.
Right.
So we usually tell them, lift up the mattress and put a bunch of pillows behind so that it's got a slight slope.
Right.
Right? And that helps to relax. And then they can walk about, they can have their normal diet, they can take shower on the 3rd day.
Wonderful.
Dressings are waterproof, there is no drain, and they can take off their garment and wash it and have a second set of garments to wear. And people who are doing office type of work can go back to office by 10 to 14 days.
10 to 14 days.
Yeah, by 14 days, I encourage them to start walking outdoors, walk on the treadmill as their body allows. And by 3rd week, they can do more exercises, but they should not lift weights, especially if their muscle has been repaired.
Right.
Nothing which will put stress on the muscle should be done for 3 months. In some bad cases, up to 6 months. But in this period, they can do elliptical trainer, they can do treadmill, they can do outdoor walking. They can climb stairs even from the first week. What else do you want to know? I mean, they can do upper body light muscle exercises, weight exercises they can do, but they should not do yoga and those kind of convoluted stretches and all that. No, that shouldn't be done.
Okay.
Anything that puts strain on the abdomen muscles shouldn't be done. But there are people whose muscle is intact. We have not had to repair their muscle.
Right.
Those people, they have much more freedom. Much more freedom. They can do anything they want.
Right.
So that's
how the journey looks like. So 360-degree dream shape with no drains, no complications, touch wood, and blood vessels all preserves. It's an amazing thing.
Sensation is also preserved. Right. The lower part in the middle, right in the middle, there they will have less sensation. That also comes back in 3 to 6 months time.
Wonderful. What else we have to add in this? I mean, this is all the key things we are adding to the procedure.
More contouring, more like six-pack, chiseled look. I mean, it's possible to do this in people who are not internally obese, who have a good musculature to start with, and who are otherwise fairly active, athletic, and all that. Yes.
And then using the fat in a better place at the same time. I mean, what can be best than that?
Of course. Yeah.
Because most of the females, I'm sure, they'll be more than happy to put that fat in the glutes area, to
not
get
always,
a bit...
Not always. I don't actively suggest procedures. That's my principle. But I let them know of the possibility that this fat will otherwise go waste. Especially for this, I say, look here, this fat, if you like, can be used in the breast or can be used in the buttocks.
So again, just to not miss out, during lipoabdominoplasty, we remove fat cells also.
Yes,
so this fat can be used in a better way in which all places to enhance?
Buttocks
in which areas?
is number 1.
Okay.
Buttocks area is number 1. Breast is number 2.
Okay.
These two areas require a larger amount of fat, especially buttocks. Otherwise, fat grafting can do for the face, can do for the hands,
Oh, face
can
as
do
well.
for genital area,
Huh.
can do, for example, some women are wanting a bigger calf area, like some people have sticky legs, skinny legs, they want more contour there.
Wow.
So fat can go into many areas.
Wow.
Right.
We will have a different podcast to talk about fats. I know. Yes, it's amazing.
Because it's got cosmetic indication, it's got reconstructive
Regenerative.
and regenerative.
Yes.
And fat is the thing to watch out for. This is the tissue of the future.
The coming era.
Yes.
Wonderful.
But yeah, this is what tummy tuck is, and I think today's contemporary tummy tuck, the way I am doing it, is got a high safety, and is very efficient, because in that 4 hours time you are totally transforming that person's
True.
body.
Absolutely.
And what's more, this result is permanent, as long as they are not gaining and losing weight and looking after themselves and doing a reasonable amount of exercise and being reasonably careful with their diet, and lifestyle. The result is here to stay for many, many years.
Wonderful.
Yeah.
Amazing. Thank you so much for such a lovely discussion, Dr. Mohan. It was an
Pleasure
honor
is all
having you
mine.
and getting it to hear it from the expert. I mean, it always makes my day discussing with you
You
all
had a
this.
nice bunch of questions,
Thank you.
which could showcase the spectrum and the range
Absolutely.
of this type of
Absolutely.
surgery.
Thank you so much. Thank you once again.
You're very welcome. Thank you.